Hey everyone, welcome to Taking the Pulse, a healthcare and life sciences video podcast. I am Heather Hoops Matthews here in the studio in Columbia, South Carolina today, being joined by Matthew Roberts, who is remote in Ohio. Matthew, a healthcare lawyer with Maynard Nexsen. Good to be with you.
Good to see you.
And in the studio today with me, I'm delighted to have back for the third time, Thornton. Thank you so much. Thornton Kirby, he is the president and CEO of the South Carolina Hospital Association. Thornton, you have been running this organization for 2 decades now?
Yeah, this is my 20th year.
20 years, and really have helped shape the industry so much in South Carolina, and I know have had an impact in other states as well, just in being as part of an association. But recently, I was reading about, and I want you to help me here with this, the South Carolina Department of Health and Human Services, HHS as we call it in South Carolina, partnered with the South Carolina Hospital Association to assist with the implementation of 13 empath grant units across the state. Tell me what those are and how they'll help.
Great. First of all, thank you for your gracious comments. I don't deserve credit for all the good things that are happening in this state, but I'll take it. So what I would tell you is that our state, as most of you all have observed in the last few decades, has not made particularly great strides in the care of behavioral health patients. We've kind of been stuck in a paradigm that's not moving forward very fast. We're not unlike most states in that regard. But our governor, our legislative leaders, our Medicaid director, Robbie Kerr, have made a big commitment coming out of COVID to try and help move or be more responsive to the behavioral health, mental health needs that we see in the population. So Robbie has chaired this planning committee, and he's let me be part of that. And so the group is looking at a lot of different components. One is adding some more beds, inpatient beds. One is working more closely with youth in mental illness in schools. But the one you're asking about is called Empath. And this is a type of unit in a hospital that's set up adjacent to the emergency room that is intended to help some of these people in psychiatric emergencies to have a much quicker resolution of their condition. They are in emergency conditions. As Matthew and I would say as lawyers working with EMTALA, they are subject to the federal laws. We need to stabilize their conditions. And the question is how to do that. There's a group of physicians around the country, particularly emanating from a group in California, a gentleman named Dr. Scott Zeller, who is an emergency psychiatrist. They have advanced a model referred to as Empath, and that's an acronym, E-M for emergency, P for psychiatric, A for assessment, T for treatment, H for healing. So emergency, psychiatric, assessment, treatment, and healing. And the model seeks to get people out of the chaotic emergency room environment as quickly as possible into a more appropriate treatment setting that's much calmer, and to get them in front of a psychiatrist or other psychiatric team to help them begin their treatment. Whereas the model in this country has largely been the emergency room is a safe place and holds the patient until they can be transferred to an inpatient facility. This is about going ahead and treating and see if we can't resolve that emergency, that psychiatric emergency for them quickly within 24 hours. There's a lot of evidence across a lot of these units around the country and around the world that it does work, and getting them out of the chaotic emergency room into a calming environment is very helpful to their condition. So Robbie said, I will give grants to a number of hospitals that want to raise their hand, and let's see if we can propagate this model and demonstrate it across the state. That's what we're doing. We're trying to help implement that. And our job really is to help standardize that and accelerate it as quickly as possible.
When did that start? When did those grants start? Last fall. So
yeah.
we really haven't had a full year of it.
No, but we have a couple of them that are already in operation because they were on the verge of doing it when Robbie made his grants. The grants actually are primarily for the renovation of space. And any hospital can do this by changing their business practices or their clinical practices. But Robbie wanted to be sure we could upfit space appropriately. So that's why he made the grants, and there are a number of them on the drawing board. And there's a lot of enthusiasm, I think, about the fact we can improve the way we care for people in psychiatric emergencies.
That's really wonderful.
It really is.
Yeah.
Much needed, and kudos to you and to Robbie Kerr for focusing on that. A lot more work to do on that, but it's a good not so first step. But I know people are working about it. Thornton, last year the General Assembly made some significant legislative changes involving hospitals, specifically around the Certificate of Need law, which has been legislatively controversial for a number of years. And what the General Assembly did is they significantly cut CON back and sunset it for hospitals going forward, for any hospital service going forward after December 31, 2026. A lot of our clients, all of your members are dealing with how to prepare for life after CON in South Carolina. What are you seeing, and how is the industry reacting to this legislative change?
That's a good question, Matthew. All of us who followed this know that CON has always been a two-edged sword. It's a protection against competition, but it's also a limiting factor or an inhibition against innovation. And so hospitals have kind of lived on that edge of that two-edged sword. And I think now they weren't excited about doing away with this policy. They felt like that was not the right legislative result, but that is very much a national movement, a trend, as you all have tracked. And I think what they recognized is, okay, we'll adjust. So we've lost the protection side of the sword, but we've gained the unfettered innovation side. And so let's go do what we've wanted to do. We don't have to spend nearly as much time going through a regulatory process to seek approval for most things we might want to expand or initiate. So I think they've recognized we're going to operate in a different environment. The hospitals in non-CON states didn't cease to exist. There is some profit taking. We can talk about that more later in the conversation, but I think they're just saying, all right, we're going to work in a different environment now.
I heard both of you, Matthew, you and Thornton, for a couple of years now have talked about CON, what will happen to it. And I honestly thought, well, it'll never happen. But here we are.
Yeah.
Brave new world.
I think the greatest concern most people have is not that we're going to close large hospitals in large cities. They're worried about the fact that there are some small health systems that are barely viable. And they're viable only because they make money from procedures. In this country, we need to deliver emergency care and psychiatric care and family medicine and primary care, dental care, but we pay really well for surgery and imaging and procedures like that. And in a small community, they don't have as much of that kind of revenue. So if someone comes and cherry picks that out or skims the cream of that, it makes it a lot harder to keep the rest of the services in place. That is the real heart of, I think, of most people's worries. And so we'll see if that comes to pass or not. But
speaking of change, also over the past couple of years, I've heard both you and Matthew talk about consolidation. Hospitals combining, companies coming in and buying a series of hospitals in the state. Where do you see us going in the future with that? Will that trend continue?
Well, that's a question that Matthew's probably as capable of answering as I am, but I'd say South Carolina was late to that party, but we've caught up. For most of my tenure at the Hospital Association, Virginia was a very consolidated state. North Carolina was more consolidated than we were, but we have caught up. By my count, there are about 5 hospitals now in the state that are not part of some kind of system. And of those 5, there are a couple of them that are pretty big systems, like Lexington Medical Center. It is a very large system. It only has 1 hospital. And so if you could say it is itself a system that doesn't depend or need others. But I think that what you're likely to see in the future is not so much additional folding in or acquisition of hospitals, because most of them have been now folded in, but you're more likely to see transfers of ownership or 2 different medium-sized systems that come together in a larger system. So there could be more aggregation, but we've kind of moved out of the phase of the independent hospital. Matthew, you think that's accurate?
Yeah, no, I think that's exactly what we're dealing with, which, for those of us, Thornton have worked in this space for a couple of decades plus. That's, we're a little bit nostalgic about that. I mean, the independent county hospital that served its community for decades as part of its mission, tied into the community. That probably, with a few exceptions, is going away, and we're going to have more regional systems that do that. So it will be different. Some of the consolidation is a perspective thing. When you have hospitals that are acquiring smaller rural facilities, like we were talking about before the podcast, that stabilizes these hospitals in a way where if that had not happened, they may have closed or significantly cut back the services they provided. That's a positive thing. On the other hand, when you see an independent hospital get acquired, the local community may not respond well to that. Or to a point you alluded to, it's not beyond possibility that a large system, a super large system, could get acquired. We've seen a lot of large scale transactions. Nobody thought Mission up in Asheville could get acquired, and it got acquired by a for-profit. And of course, there's been massive community backlash 2 years, 3 years after the deal. But so I do think we're going to see different types of consolidation in the future. But it's definitely hit South Carolina, and its impact, I think, has not been as negative as some people may have expected, but it's certainly different. So Thornton, South Carolina is one of the 10 states in the country, one of 10, that have not made a decision to pursue the expansion of Medicaid. This has been a massively beneficial thing for states that have expanded Medicaid from an economic development type of dynamic, notwithstanding the politics. It has just benefited those states as a matter of math. We know that folks in the hospital industry would like to continue to have South Carolina to pursue that, but where do things currently stand for that, for South Carolina and Medicaid expansion, and what impact would Medicaid expansion have on patients if we ever did move in that direction?
Well, let's start with the last question first and get that one out of the way. There are many people who don't seek care at an early stage when they're not feeling well because they don't have insurance, and they end up going to the emergency room. So without talking about politics, if we were trying to build a cost-effective system, we would intervene as early as possible, not wait until a health condition becomes fulminant and then expensive, right? But that's not how we've done it in this country. We've left a lot of people uninsured. So a lot more South Carolinians having insurance would probably encourage more of them to seek care early, particularly prenatal care, particularly folks who need to manage diabetes and cholesterol and high blood pressure and things like that. So there are a lot of uninsured adults in South Carolina. It would be very helpful, I think, not just to the provider community who could have a form of payment, but also to those individuals who would presumably seek care earlier, which means better health status. Now, the
evidence in the other states have shown that, right? The states that have expanded Medicaid, the data supports that position.
That's right. And so, so one of the interesting things, Matthew, the southeastern states have been some of the slow ones to come along to the party. And one of the interesting conversations that we're hearing over in Mississippi and Alabama is those states are looking, to your point, at what impact Medicaid expansion has had on other southeastern states. And what they're finding is the workforce participation rate is higher in expansion states. Now, that's not the same as, I'm not an expert on this, but that's not the same as unemployment rate. Unemployment rate measures how many people who are seeking jobs can't find them. Workforce participation is all the people who aren't working, who could be working. And Alabama and Mississippi have advanced their Medicaid expansion bills based on the notion that they want a healthier workforce, and they want more people in the labor force because it's so hard to find people to work. The workforce is tight, and if they can do anything that gets people healthier and into the workforce, they want to consider that. So I think you're going to see more southeastern states going down that path. In North Carolina, it was a bit more of a kind of a master bargain, I think, when they did a CON and a Medicaid rate issue and tied all that in with expansion. But some of the other states that are looking at it on its own are looking at it for the benefit to the economy and to the employment of their citizens more than health status.
And workforce is important, particularly in these southeastern states that are competing for new jobs, new companies to relocate there because it's a pro-business state. And
right.
having a healthy and adequate workforce is critical component in that competition for industry.
Absolutely. And Senator Tom Davis has put that in his healthcare marketplace study bill or study committee proposal he has. And so it's been interesting to us that Republicans are now talking about those two words together in the same sentence, Medicaid and expansion. So we'll see if they will maintain that. It has.
Another thing that's changing is where we get our procedures done that you spoke about that really are the bread and butter of hospitals. We've seen more of a move to like ambulatory, and even there's been hospital at home that you can choose from now. What are trends that you're seeing? Where do you think they're going? And what does it mean for a patient? And whether you're getting care where you are or you're going to a hospital or what?
Well, you've hit the nail on the head. It's a trend. People who can get care away from a hospital are more likely to get it elsewhere. I was just doing a talk last week about kind of how we got here with our healthcare system and the history. And hospitals were started to care for the poorest of the poor. If you had resources, the doctor would come to your house. So churches and other charitable groups would form hospitals, and that was for the poor people who had no access to physicians. Well, now we're not the poorest of the poor in hospitals. We're the sickest of the sick. So, when we started in this industry 20 or 30 years ago, there were sick people in hospitals, but it's much more like a hospital full of ICU patients now. They're very sick, and that's because people who need a hip replacement and who are otherwise healthy might be able to get it on an outpatient basis. And people have a baby and they don't stay 7 days, they stay 24 hours. And so the people who are in hospitals have real complex medical problems. So I think what I hear from some of our thought leaders like Dr. Pat Cawley at MUSC is we're always going to be taking some things out of the hospital environment to less intense settings, and that's good for patients because they aren't exposed to as many infectious diseases. But there are going to be more and more things as technology advances that require hospital level of care that we couldn't do 5 years, 10 years, 20 years ago. So I think you're seeing a constant filtration. People who can get out of the hospital, we need them out for their own benefit. But there are more things and more sick people who need to be in.
And a prime example of that is as we move to treating people where they are, you look at COVID, it was hospitals who saved the day with COVID, along with the life sciences industry, because there was nowhere else to go. And the hospital employees, hospital physicians, they all banded together and did something that no one thought was possible. And it's a little bit peculiar that more hospitals haven't gotten the benefit of that bump in how people were perceiving their local hospitals, because they played a super, super important role in responding to this pandemic and to trying to improve the health and wellness of its communities. But if you didn't have that inpatient component, COVID would have been 30% worse, if that. So, but I do think that's a trend as we move toward digital wearables for patients where they can get treated and get monitored while they're sitting at home watching TV, and more to come on that. Thornton, one last thing, we mentioned this, we alluded to this in the CON question, but more and more we're seeing new players in the healthcare delivery business beyond hospitals and physicians. We're seeing private equity come in, take ownership of sort of niche positions within the healthcare delivery. We're seeing insurance companies do this, and with Optum Health, which is the largest employer of physicians in the country, and Optum Health is a parent company of United Health Group. So what are you seeing in terms of this trend toward private equity investment and non-hospital ownership of healthcare delivery systems and providers? And what do you think that's going to have? What kind of impact will it have on our healthcare system and patients?
That's an interesting question. I was just in a national meeting where this was a lot of the conversation. I would say, I don't think this is a different type of competition than we've seen in the past. I think in the absence of CON, it may be less constrained. But what we're talking about, what you're describing is really profit taking in healthcare. How do we recognize there's a lot of money to be made, and private equity money is not generally focused on charitable or free care. It's focused on lucrative. specialties. So you don't see private equity trying to scoop up pediatric practices or psychiatric groups. It's more surgical, GI, whatever, orthopedic. I think that in this national conversation, what was interesting to me is hearing the said in not so many words, the concern that private equity is trying to extract profits out of a business where the underlying business doesn't actually generate that much profit year to year. So
and whatever profit is generated is reinvested.
Right. So I've heard a lot of hospital CEOs tell me that one of their practice groups, specialty group, gets acquired by a PE group and they own it for several years. And then the senior partners retire and exit and they have a nice windfall and the younger partners are left without much, and they come back to the hospital and ask to be reemployed. And so the hospitals feel like they're in this cycle. Somebody took a lot of profit out of that practice and now wants the hospital to come back in and subsidize it back into the community. I don't have a strong feeling. I think there are a lot of arguments pro and con here, but I do worry that there are efforts in this model to pull out of a physician practice more money than it actually generates. You do that by some creative financial means, and then it's left kind of as an empty shell.
Well, there's no doubt that private equity is designed it exists to create additional profits and revenue. It just and primarily in the relatively short term, on a short term basis, 3 to 5 years.
Right.
So we see this as an increasing trend. We're seeing more of it, but it is very specific and, to no pun intended, very surgical how this investment is being made. There are some PE purchases of hospitals, general hospitals, but you see a lot more on the specialty side of things, ASCs, other practices where they're following the money, specifically following the payer mix. And we'll see how long that continues. The FTC has brought private equity under the microscope based on some of its purchasing habits and strategies, and we'll see where that goes. There's a lot that the FTC thinks is wrong that isn't wrong, but time will tell how this evaluation of the private equity market will work from the antitrust perspective. But I do think this is something that we'll see in South Carolina for the immediate foreseeable future.
Let me just say the last observation I'll make is I did talk to some folks with large construction firms who had an initial flurry of interest after the CON law passed from physician groups who wanted to build ASCs. And then when they started doing the pro forma and realized anybody else can build another ASC on the opposite corner of the street, they were less interested because they don't have the monopoly, just like the hospitals don't have the monopoly. Nobody, if everybody can compete, then you can't count on any particular volume because your competitor can come in and do everything they can to try to undercut you. So it's interesting. It's a market phenomenon, I guess.
One of the underlying policies behind the CON push was to create competition, which we're all in favor of, but competition means they're going to be losers. And I think that's dawning on some people right now, what that really means when you have a more dynamic market.
Well, what's clear to me from listening to both of you is that there's a lot of change in the healthcare industry. And it seems like since COVID, it's just come faster, or maybe since COVID, we're all more aware and we're looking at healthcare more. But Thornton, thank you for, again, 2 decades of you've really fostered collaboration in our state. Like, you've been a champion for that. I've watched from the sidelines, and we're grateful for that. And thank you for joining us again for the 3rd time. Hope to have you up for 4th.
Man, it's always an honor to be invited. I'll come anytime you like.
Okay, thank you. Matthew, be well in Ohio. Look forward to having you back. And for those of you who joined us today on Taking the Pulse, we hope you enjoyed this conversation with a couple of thought leaders in this industry in the Southeast. And we look forward to seeing you next time right here on Taking the Pulse, a healthcare and life sciences video podcast.